All right. How's everyone doing? Good. Everyone's good? Say that again? Still trying to stay awake. Okay, awesome. So I'm looking forward to this. First off, I just want to say thank you to Al and Al Quinones Seminars Board of Directors for inviting me here today. Can we put our hands together for them? And definitely appreciate this invite. So I'm going to try my best to not move around too much, okay, and speak a little bit slowly. If I'm speaking too quickly, you can just raise your hand and you'll know that, all right? So I have the opportunity today to talk about innovations in equipment and application. Equipment matters, so it's a little bit, I found it interesting and fun to bring you the equipment that I've been in use with. And we'll go through the slides and we'll see where we go from there, okay? I'll take some questions towards the end if there's any questions that you might have. So my quick disclaimer, I do not have any financial interest in the products that will be discussed. Slide credits goes to Dr. Howard Hyman from Hillrom and Breathe Technologies for the devices that I'm going to be speaking on. But yeah, so some slide credits to them, and I'll mention those names when I do bring up the slides that they will be speaking about. Objectives, we're going to discuss the need for innovations in equipment, discuss the use of airway clearance devices, discuss the Metaneb, the sinusoidal bronchotron, pretty cool name, right? Sinusoidal bronchotron, and the Life 2000 devices and its applications. So before I get to the slide, have any of you heard of those devices that I just mentioned? The Metaneb, those from the facility where I work. I'm sure you've heard a lot of that. The Metaneb, any of you with the sinusoidal bronchotron? Sinusoidal bronchotron, and also the Life 2000. Any Life 2000, you've ever seen that? So, okay, wonderful. So we're going to learn a lot about those today, and we'll see what is happening. But what is innovation? When Al presented with me the topic, and it had innovation in it, I had to just really dive into what innovation is, right? And the Merriam-Webster dictionary defines it as the introduction of something new, a new idea, method, or device. And that's really important for us today as RTs, right? Why is this important to us? It is important to us because, you know, with the healthcare model changing and all these different things that are happening, we need to be on top of our game. We need to keep growing and getting more involved with patient care and doing better things for our patients, improving their care, improving their outcomes, and most of all, their quality of life. Because it's not just about caring for them when they're in the hospital. We also need to find out what's happening with them when they leave the hospital so they're not coming back. And not just because of the readmission issues that are happening, and I'm sure all of you have been hearing about that. We want to do what's best for our patients. So the first thing I want to talk about is airway clearance, and something we've been doing for the last couple of years at my facility is we've been dealing with airway clearance to a different level, and but we've been doing certain things for many years. I haven't been an RT. I've been an RT for about 8 years, and you know, we've been doing some things that's been done for many years, and you're going to see a couple of these that you've seen already. But for airway clearance, we've been using suctioning, meds, chest PT, IPV, cough assist, and vest therapies. So we've been doing some things for our patients for a very long time now, but I feel like we need to grow on that point, and we need to be doing more in-depth things when it comes to airway clearance. And one point I wanted to throw out here is that did you know that the respiratory tract produces about 2 liters of mucus a day, right? Right? That's actually a fact. That's a proven fact, and that's normal, right? That's normal. Think about the disease processes that causes these the amount of mucus to be increased, right? But I threw this slide in here to prove and to show that, as a matter of fact, being intubated and being in the hospital does not stop the amount of mucus that is being built up in the lungs, and we're expecting them to bring it up so that we can help them clear it out. And you're going to see the type of devices that we use to help them take it a step further, okay? So how airway clearance works, really basic. I'm not going to spend too much time. I love pictures, and I love to just show the way how things are. And a lot of the presentations that came up until this point kind of spoke and they touch on certain points. And I believe it was Rachel that spoke about the cilia and the mucociliary escalator. And that's kind of what it looks like, right? There's mucus blanket, there's a cilia, and it takes the mucus and helps clear out the debris that can end up into your lungs. And how do we get it out? How do we cough it out? There's an irritation, right? Then there's inspiration. We take a deep breath in. Then there's compression. and then expulsion, okay? And I just want to throw that out there, that when you're coughing, you shouldn't be opening up your mouth like that, all right? So I don't want to see that. You really should be coughing into your, right, the Dracula cough. How many of you do that? How many of you are annoyed by when you're going to shake someone's hand and you just saw them cough into their hand? And you don't want to be rude, right? You don't want to be rude, but guess what? You're just kind of like, you just kind of wing it, okay? All right, good. So yeah, that happens to me too. So, so what affects airway clearance? What affects airway clearance? There's changes in the rheologic properties, and what that means is the fluidic move of how the cilia and how the mucus is carrying the debris out of the lungs. Then there's the mucociliary clearance defects, ineffective cough, reflex or mechanism, and then that kind of contributes right over into infection, inflammation, airways obstruction, and parenchyma damage. Right? So then we have intubation. So what happens then? That whole process that I showed you the picture of earlier, could the patient do that now? No, right? We've just impeded their ability to do their natural mechanism of coughing out whatever is into the lungs. And patients with an artificial airway will have an impaired mucociliary action. Notice I had lunch and I can actually pronounce that, right? This morning I would have bitten my tongue. But impaired mucociliary action and impeded mucus clearance. So look at how that ET tube sits. That cuff is inflated and inability to cough out, okay? And just that's a lovely visual to see and to show that, and credit to John Fahey for that lovely picture or drawing, I think it is, of how that tube sits there and the cuff is inflated, and we're expecting them to bring the patient to bring up all this mucus, right? And then we suction it out with a suction catheter, right? But we're expecting them to bring it all up. Are we really helping them to get it up? Because a lot of them cannot, okay? And that's what we want to be able to help them with. So early signs of mucus retention really quickly: increased FiO2 requirement, increased peak airway pressures, decreased lung compliance, and you know all of these: increased air resistance, persistent rhonchi, decreased breath sounds. How many of you have heard a nurse called you and said the patient sounds junky? Right? Do you get annoyed? Okay, is it just me? Is it just me that gets annoyed that the patient sounds junky? Okay, all right. I just wanted to throw it out there. So chest radiograph indicating atelectasis or infiltrates and breathing patterns, right? So what do we do now? I heard one of our colleagues back there had mentioned that he didn't change the Ballard last night, right? So what do we do now? So we have the Yankauer, we have the, for the trach and intubated patients, we have the Ballard, that's the clothesline suctioning, then we have open catheter suctioning. So that's what we do now, expecting that our patients can bring up the mucus. Bronchial hygiene medications is another route that we take. So we have bronchodilators, and we have inhaled steroids, we have mucolytics, we have expectorants, and we know these meds. I'm not going to spend too much time there, but we try to help our patients get the mucus out. And keeping in the thought of innovative and being innovative and doing something new, how could we get our patients to clear their lungs more effectively when they're in our care? And not only when they're in our care, what could we do when they also get home? So another set of things that we use now are we use the bed percussor. I don't believe in that at all. I think it's a free massage, but I don't know about you. I haven't tried laying down in one of the beds yet, but I think I want to do it one of these days. But anytime I try to go in an empty room, at my facility, before you know it, another patient shows up. So then we have chest PT, right? Right? Anyone have ever had to do that before? Right? You've ever had to do that? Right? You use your hands, or you use an ambu bag, the mask? Right? Hands, okay? Yeah, that's where masseuses came out of, actually, I think. Okay, that was a joke. But yes, so, we have the acapella as well, and then we have the aerobica. So, whichever one of those that you use, we try to help our patients clear their lungs. Okay? So, another level of therapy that we try to help our patients with. So we have the chest vest. I put both brands there. I have I just wanted to make sure I did that. And then we have cough assist, okay? How many of you love using cough assist, right? Cough assist, yeah, I see a hand back there. All right, lovely. So cough assists are great, okay? Not very appetizing, but they're great, okay? So the thought process is we're trying to suck out whatever is down there. So, what about the vented patients, and where can we take our mindsets in growing and becoming more advanced in airway clearance for our patients? So, I brought up the MetaNeb and the sinusoidal bronchotron. So, there are two devices that we've been using to help with airway clearance, and we'll talk about the MetaNeb in an overview really quickly as we move forward. Can be used non-invasively and invasively. The sinusoidal bronchotron, for the most part, is the transport version of the VDR. Anyone heard of the VDR? The volumetric diffusive respirator. So it's a transport version, and it helps with airway clearance, and it also ventilates. Just want to point out one thing. The MetaNeb needs a mechanical ventilator for ventilated patients to help clear the lungs. The sinusoidal bronchotron takes over the entire work of breathing and also clears the lungs, okay? So, and we're going to see more slides on that. So the MetaNeb system, 3 therapies in one device, right? 3 therapies in one device. There's lung expansion, right? CPAP, continuous positive expiratory pressure. Then you have airway clearance, which is CHFO, continuous high frequency oscillatory or oscillations. And then there's aerosol delivery. So you have the ability to provide 3 modalities of therapy to this patient with a mouthpiece. And I'll show you a slide in a little bit of the different types of interfaces that could be connected with the MetaNeb. There's a running joke at my facility that if I get enough patients on MetaNeb, they will call it the Mootoo neb, okay? But that's not true, okay? My name is Mootoo, so that's why they say that. But the ability to provide supplemental oxygen, and as I said, I have no financial affiliates with the MetaNeb company. I need to throw that out there. But the ability to provide supplemental oxygen provides metatherapy treatment, multiple treatments delivered simultaneously, alternating lung expansion, right? Lung expansion, CPAP, and secretion clearance therapies, maintaining PEP, and delivering aerosol throughout treatment. So it's a lovely combination to help our patients. And remember those medications I was mentioning earlier that we help with clearing the lungs, it can now be introduced with the percussive and the ability to provide oscillations into the airways to provide airway clearance. So the MetaNeb system is an IPV device, really. It uses a pneumatic interface called a phasotron, right? Phasotron. It all stems from the Bird, Dr. Bird, and you'll see a picture in a little bit with that. And it delivers high flow mini bursts of air into the lungs at a rate of 100 to 300 times per minute. There's a high rate, a low rate and a high rate. You get about 170 on the low and 230 on the high, depending on patient compliance of how much they can handle. In my experience, and I don't know for those of you that have used it, the patients usually like the higher rate of oscillations. It's a little bit more comfortable for them to breathe with. But when you're on mechanical ventilation, you need the much higher frequencies. So the standard therapy for mouthpiece or mask is a 10-minute therapy. So you get 2.5 minutes of CPAP, which is lung expansion. So we're giving nebulization therapy while expanding the lungs. Then you're getting 2.5 minutes of oscillatory effects with medication continuously going through. And then you have 2.5 minutes of CPAP and then 2.5 minutes of oscillatory. So you get a full therapy with that 10 minutes, 2.5 minute intervals. And if you still have more medication to give, there's an aerosol option where it can just give the aerosol therapy without CPAP or without the oscillations, okay? I call it a really expensive AeroNeb, okay? So that's kind of what we could do there. You could see the applications on the bottom. We have the ability to do it with a trach. We have the ability to connect to a mask. We have the ability to connect to a mouthpiece. And then mostly used at our facility right now, we use it in line with mechanical ventilation, and I'll show you how that looks in a little bit. So another description here is the MetaNeb system is indicated for mobilization of secretions, lung expansion therapy, the treatment and prevention of pulmonary atelectasis, and also has the ability to provide supplemental oxygen at the same time because it's being powered by 50 psi oxygen, but it entrains air so you're not getting 100%. I think I mentioned, and on the bottom here, credits to these slides go to Hillrom for their MetaNeb presentations. So in line with a ventilator is what I really want to talk about today. While we use our CF population have been loving the MetaNeb system in-house, we use it in conjunction with our vest therapy, the chest vest external, and how we like to explain it to the doctors, and how when you bring this back, and I hope you bring this back to your departments, your hospitals, your facilities, and you advocate to have these type of therapies done. What the chest vest does externally for your patients, the MetaNeb now does internally, okay? So the effects of it are much stronger. So in line with a ventilator is where we have taken it to the next step. We've taken it to the next level of airway clearance, because what were we doing before, right? We were just expecting them to bring up the mucus and the phlegm and whatever is down there, and then we were suctioning it out. But now we have the ability to, while they're being ventilated, send vibrations down into the airways and help clear those lungs out. Now, mind you, on the ventilator option of the MetaNeb, we do not use the CPAP therapy because we're already getting PEEP. And stemming from the last presentation we just heard, you've heard of the cardiac effects of PEEP and all these different type of pressures going into the lung. And if we start adding all these supplemental pressures with the MetaNeb, it could cause more issues. All right, so we want to make sure that we pay attention to that as well. So in line with the ventilator, this is a great picture of how it would look. What we do is we like to use the pressure control mode. So if your patients are on volume control, for those of you that have used it before, we get a plateau pressure, right? We convert them over into the pressure control mode, and then we institute the MetaNeb in line. And there's a nice little picture on the bottom showing a respiratory therapist introducing the phasotron into the vent circuit in the inspiratory limb. Some hospitals do it at the humidification on the dry side, and then some do it closer to the patients. What I would say is our recommendations for our pediatric population, we go on the humidifiers. For our adult populations, we go closer to the patients. Why? Just for the sake of the size of the lungs and the sensitivity of the patients that we're treating. But you can see it looks pretty cool, right? On PEEP levels and on our PIP levels, we see the oscillations taking place, and it's sending continuous percussions down into the airways, helping mobilize and break up those secretions that are down there, and thus helping the mucociliary escalator to bring it up and help us to clear out those lungs. And we've seen great improvements with a lot of our patients with the MetaNeb therapy. The company actually suggests up to Q4 hours for 48 hours, and then reassess and go to QID, BID, or once daily, whichever method you choose. But it's limited in the aspect that it's intermittent, and we can't do it continuously for our patients, and some patients need a lot more than intermittent therapy, and that's where we're going to flow into the sinusoidal bronchotron in a little. But you'll notice that if you see the vent settings there, is there anything that stands out to you with those vent settings? How many? That's an Avia. Anyone uses the Avia? The Avia, right? Anything stands out to you with those settings? Right, we've locked the flow, right? We've locked the patient out because we want to control the breathing, the cycle. And then another thing is that number 2 right there. What's that? That's the I time, right? So what we've done, we've lengthened out the I time, right? We've gotten a 2 second to 2 second, IE ratio and inspiratory to expiratory time, so that we can lengthen out and control the breathing cycle. Is it the most comfortable thing in the world? No. Being on a ventilator as a basis is not the most comfortable thing in the world, but you go with patient compliance. This was an adult patient. For our pediatric population, we will not go to 2 seconds. We go to much lower than 1 second, about 0.8, 0.6 for our smaller kids. But I just want to show you, for an adult patient, we would get away with that amount of I time and try to equal out the I to E ratios, okay? So that's MetaNeb in line with a ventilator. Mind you, we are also giving medications as well while we're providing this therapy to our patients. So a couple procedure-related risk factors. So there are a couple things that causes atelectasis. So I've been talking a lot about airway clearance, but the MetaNeb also helps with lung expansion for the non-invasive applications. And there's a lot of surgeries and different type of things with surgical sites. And I'm not going to go through all of them, but you can see there are a couple things that are happening that can affect and cause atelectasis to take place, and a lot of things that can cause for us to have secretion removal as well. There's patient-related risk factors for pulmonary complications, and their age, smoking history. We talked about the smoking cessation and those different presentations that took place today. They affect the ability for you to clear out mucus, and it's a revolving effect that leads to and trends into death for the most part, and immunosuppression, recent respiratory infection, obesity, weight loss. There's a lot of patient-related risk factors here. and studies to back them up as well. And there's additional risk factors for patients with chronic disease, COPD. We heard a lot about that today. Cystic fibrosis, I mentioned to you, our CF patients love them. They actually use the metaneb in conjunction with the vest because their ability to clear their lungs are even worse. It's even, their inability, it's just horrible. And whatever we could do to help them, we've seen that metaneb as well has been helping them. The problem with the metaneb therapy, or I'm not saying problem, there's an opportunity for improvement, I should say, is that it's not approved for home use just yet because of the 50 psi connection, okay? So it's something that needs to be looked at, but there's chronic neurological disease. Those neuro patients also have those issues with clearing their lungs, and you can see that is a benefit as well. So there's some contraindications and adverse reactions with anything, with all devices that we may see, but there's absolute, there's relative, and then there's possible. Absolute, one of the biggest possible contraindications with any respiratory device is an untrained or unskilled operator. Amen. I said amen. I'm a preacher or a pastor, and that slipped out. Yeah. You know what? I was not going to say it, and I'm thinking someone just mentioned that to me. You need to edit that, sir. Someone mentioned it to me as a joke, and then it slipped out. Anyway, so yes, I also do that outside of here. But anyway, back to absolute contraindications. That wasn't a joke. That was real. So absolute contraindications. So you have untreated tension pneumothorax. You have history of pneumothorax, pulmonary air leak, recent pneumonectomy. So pneumonectomy is not a absolute contraindication. I threw that in there, and you may say, why not? Recent pneumonectomies will be an issue, but if you've had a pneumonectomy many years ago and everything's been healed, or not even many years ago, if it's been healed, you can have this therapy as well. And then possible adverse reactions flows into hyperventilation, gastric distension, pneumothorax, pulmonary air leak, and a couple of other things that are there. So as we close off on the metaneb system, patients on mechanical ventilation from ICU to extended care, and as I said, as the healthcare model is shifting and you're seeing a lot more patients getting home care therapy and outside of the hospital setting, we need to adapt, all right, and get into that ability to be able to treat our patients outside of the hospital as well, and let them be able to care for themselves as well at home. You see that continuous pulses of positive pressure oscillating airways to mobilize secretions. That's for patients on mechanical ventilator. Then you have post-extubation management, helps to prevent respiratory complications, all of those procedure-related risks that I mentioned for atelectasis and retained secretions. And then floor therapy prevents reverse atelectasis and aids in the mobilization of retained secretions. And then for extended and long-term care, we have enhanced secretion removal and helps to prevent and resolve patchy atelectasis. So there are a lot of opportunities for this device to actually be in application, and you can see that very well here to improve our outcomes. So then we're going right into the sinusoidal bronchotron. So I mentioned that the metaneb therapy is more intermittent, okay? And as it being intermittent, you can see that you don't have the ability to provide long periods of airway clearance and percussing ventilation breaths into the airways. So IPV comes from Dr. Bird and the sinusoidal bronchotron. I had the ability to travel down to Sandpoint, Idaho and meet with Dr. Bird a couple years ago, thanks to the leadership of my facility, and I was able to go down there and receive training on the VDR and the sinusoidal bronchotron, and it allowed me to be more versatile and be able to provide all these different type of therapies to patients just because of that training. And you can see I got a certificate from Dr. Bird, and he rest in peace, but I had the opportunity to meet with him, and it was a great opportunity to do that and to get training as well. But intrapulmonary percussive ventilation, it comes from Birdian flow, okay? Dr. Bird, Birdian flow, is the pulmonary circulation created by the phasotron. So you hear that word again, phasotron. So it all flows back to this, a unique open circuit air acceleration delivery system invented by Dr. Forrest Bird. The Birdian flow bathes the alveoli in fresh oxygenated air while gently washing out CO2 and secretions, okay? So that's a very nice statement, right? The Birdian flow bathes the alveoli, right? If you were to explain that, that's a lovely explanation there. Another way I like to explain it is, there's an elevator versus escalator thought process to have here. Conventional ventilators are the elevator way of delivering a breath, okay? You basically touch the floor you want to go to, it takes you downstairs, and then it releases you there, and then it comes back up. The elevator mechanism of delivering a breath. Then there's the escalator version of delivering a breath. And if you picture being and visualize being in an on an escalator or going down or up, it takes you up, and it's kind of like chipping its way up the stairs. It's not just that sudden movement up or down. And that's what you're going to see as we talk about the sinusoidal bronchotron. There's an escalator methodology here of how the breath is actually being delivered. So I was really hoping this video can play, but for some reason, the PowerPoint presentation here is not picking up the video that was embedded, but you can get a visual description of what this is. It flows back to, you know, the Newton's third law, basically, of laminar flows and how this is going, where as the water flows down into the glass, right, it goes down the middle and shoots up the sides. And that's how the breath is being delivered with a sinusoidal bronchotron. It's high frequency bursts of air down the center of the airways, right, shooting down the center of the airways, and while it's coming back up, it's removing the debris and the mucus that is plugged and it is blocking up the airways. And if you could visualize the glass, I don't know how many of you have ever done that with your sink, and you've seen you're trying to like fill the cup up. I don't like doing dishes, so I like to fill the cup up with water so it doesn't, you know, anyway. But, you know, so pretty much I fill it up, but if you keep having that water filling up the cup, it goes down the middle and it keeps overflowing through the sides, and that's the methodology of how the breath is being delivered here. This would have been a great video to watch, and you could actually go on YouTube and pull it up. It's under Birdian Flow. You could actually see this video, and it's such a great description of how the breath is being delivered, where the air is coming out in sudden high frequency breaths, and it's just chipping away at that debris. It's chipping away, and as it shoots down the middle, you'll see the arrows showing you how the breath is going up either side, and it's a lovely depiction of how the sinusoidal bronchotron actually works. Okay, good. So I thought I said amen again. I thought it slipped out. But yes, sinusoidal bronchotron, it takes over the work of the mechanical ventilator and also provides airway clearance. And how you choose those settings, the respiratory rate basically flows the same as the conventional or even lower. Then you have the FiO2, which is the same as the conventional, but you have to consider air entrainment, which lowers the FiO2 you have dialed in because of the phasotron and how it entrains air, and you'll see that in a little. You can get a lower FiO2, but in our experience, we've noticed you didn't even need a higher FiO2 because of all the lung recruitment that was taking place and the atelectatic lung opening up. We actually did not need more FiO2. The total PIP that we have set, we go off of a plateau pressure for volume control, and then there's pressure control setting. You would just keep with the pressure control ventilation setting. And the PEEP, this is an important point to know. You cannot be PEEP afraid or PEEP scared. You have to start with at least a PEEP of 8 to see effective therapy when you're using the sinusoidal bronchotron. And 8 to 10 is where we usually start at. And you could also do nebulizer therapy and nitric oxide therapy. I like to throw that in there because a lot of our patients are also on those type of therapies as well. This is a slide that I worked on for months to get an educational slide together to basically put together perfectly with the help of my leadership at my facility, where we can explain how the sinusoidal bronchotron works. And in a nutshell what it is, because my time is going here, but in a nutshell what it is that you have I time and E time. You go back to the basics of respiratory therapy, where you have I and E, and you calculate the total cycle time, and you divide by the seconds and 60 seconds, and you get a respiratory rate. You go right back to the basics of that. Then you have pulsatile flow rate and oscillatory CPAP. Dr. Bird didn't like the words that everyone else used. He liked his own words. So oscillatory CPAP is PEEP, and pulsatile flow rate is PIP. It's the total PIP the patient was receiving. So you have an operational pressure knob here. That's basically what powered the ventilator. And then you had that little gray knob there. That's what made it a high frequency device. That's what basically defined how many high frequency breaths was going to be delivered per minute. Okay? So basically the I time is how long you spend in your pulsatile flow rate. The E time is how much time you spend in the CPAP range, and the high frequency is how much high frequency breaths it was chopping the air at. Okay, and that's simply put of what it is. And you'll see another slide here. So basically, this is what defines it as a sinusoidal bronchitron. You see how it mimics what a conventional breath would look like on a flow rate on your ventilator. It mimics that by having how many of you use APRV, right? There's a T high and a P high, a P low and a T low. If you think about it in those methodology, you can see there's a time that you spend in the PEEP level, then there's a time you spend in the PIP level, and then there's a time you go back down. And as it flows, that's what gives you your respiratory rate, but it's not really a respiratory rate. It's just based on the I to E, you get a total cycle time, which refers back to a respiratory rate. So I'm not going to spend too much time here. You're going to get the slides and you'll see, but it's just basically, it's really a fancy pressure control ventilator that uses flow, and what makes it high frequency and causes the percussive and diffusive aspects of it is the high frequency, and it goes from anywhere from 200 breaths per minute up to 600. And the lower the frequency, the more percussive and the more heavy lifting you can help to clear out those lungs, okay? So what should we be doing is basically we should be implementing some type of airway clearance therapy to our patients greater than 48 hours or even sooner who are mechanically ventilated, because we can see that our patients can be impeded with having basically having their airways cleared. And what I wanted to mention was in practicality, we've actually had our patients just most recently, post-operative ECMO patient, really plugged up, we couldn't get the patient off of 70% FiO2, PEEPs of 7 to 8, could not get off the ventilator, trached and vented, and they couldn't get anything out. They can only bronch so far. They can only help clear out so far. We actually threw the patient on the bronchitron for 3 hours one day, then 4 hours and 4 hours for the last couple days. The patient's now on 40% FiO2. Actually, the PEEP is, I think, down to 5, and there's a possible, I think tomorrow when I go into work, we're going to try trach collar or something. We're going to push the patient and see where we can get to. So this is a continuous ability to provide airway clearance, but noticing this is still a transport version of the device, and we can only do it for a certain amount of time because it doesn't have alarms. But there's a VDR option, which is a bedside version of this ventilator that if you want to do further research, you can look up on, and you can see that there are mechanical ventilators that can help those patients as well. Okay? I'm sorry if I'm talking a little bit faster. I'm trying to get to these slides. But pretty much just this quick presentation, then we'll move to the Life 2000. That's a pretty cool ventilator I want you to see. But a quick presentation here. As a 9-year-old extreme respiratory failure from influenza B, MRSA, pneumonia, ECMO candidate, the patient's 60 miles away, fastest, safest transport is the helicopter. At my facility, respiratory therapists don't go on the flights because there are only 3 or I think 2 seats in the back and 2 seats in the front, and they take a doctor and nurse, and then there's the flight paramedics that are on there. But for this specific transport, Dr. Howard Hyman, who gets credit for a lot of these slides here, he actually said that if Stephen doesn't go, I'm not going. Stephen with a PH, there's a Stephen with a V here. But pretty much, what's happening is, he said if the respiratory therapist is, not credit to me, but credit to the profession, that he saw the value in respiratory therapy, that he said, if the therapist is not going, I'm not going for this patient. And he was able to say, and that's why it flows right in with innovation, to say that, it came from the training with the sinusoidal bronchitron, and then this case presented itself that when you prepare for what's coming in front of you, and then when it happens, you're ready to go, and that's when you're able to really shine. And it wasn't me. I believe that our department and our profession shined that day when he said this, and you'll see the outcome that actually took place with the sinusoidal bronchitron. So we adapted to the sinusoidal bronchitron, INO delivery, which needed nitric, systems from the NICU to PICU transport platform. We needed the leadership approval to have them lead them off. Then I had to take a picture. Actually, I didn't want to take the picture. I didn't want to take the picture. Actually, my director forced me. Do you see my face there? I did not want a picture, but yeah, she made me do it. So yeah, I'm really doing this. They called on us to go into helicopters. I've never been in a helicopter before, but I love things like, I loved exciting things like that, so it actually fell right into place. So helicopter transport, we went to Manhasset, we went basically to the helipad, and we were on our way. Yes, I took a selfie in the helicopter. At that point, I was like, you know what, it's happening. Let's just make the best of it. I was like, I'm going to be presenting at Al's seminar one day, and I'll need this picture. Okay, so pretty much the HFOV, the patient was on 2868.3. That's MAP, delta P, and the rate, the frequency. So pretty much FiO2 100%, 20. Air trapping, atelectasis, infiltrates, secretions. They were preparing this family that this patient was going to die. We were transporting just for ECMO purposes. We brought the patient in, we put them on, we went there, we took the sinusoidal bronchotron, we put it in, means of 26, 28 to 30, pulsatile flow rates, the rates per minute, we kept it around 30. The high frequency rates, we started low around 300. We kept the nitric around 20. So ABG results upon arrival was 709, 112, 70. Okay, actually it was undetectable at some points, and they got it spotty gases, and we don't even know if this was even real. It was coming up question mark. How many of you run blood gases? Question marks. It was undetectable. The sinusoidal bronchotron initiated. ABG results after 30 minutes. We got 7.2, 100, and 140. So we knew something was happening right there and then. We were not only clearing the lungs, we were ventilating, we were oxygenating, and that's the beauty of the sinusoidal bronchotron. The results were trending in the right direction, so we were off to CCMC. So this is in the air here. That's the aeronox, just to show you how crazy it was in there. That's the bronchotron, that's the monotron, the phasotron, all the parts of where it was. Then you have the patient monitor. I'm sitting in that place there, somewhere crunched up against the corner, the ET tube, and the nitric tank. It was a crazy setting that was there. But then this is kind of the outcome flow of what it was. So we went from 709, 112, 70. Then then we went to 714, 102, 121. And from 120 minutes being just on the sinusoidal bronchotron, no ECMO, no nothing, just being on the sinusoidal bronchotron, 724, 71, 115. So there was a significant improvement with this patient here, and it was an eye-opener to the physicians at our facility to see what took place. So patient and sinusoidal bronchotron development team, that's Dr. Howard Hyman. He was a great advocate for respiratory, and he still is till today. No ECMO, HFOV to SIMV to room air, and from preparing for death, 1 week later, home 17 days post-op transport. Okay, that is something awesome and that's what innovation does. Innovation truly takes you to the place where you impact lives, and that's what matters. That's what matters when we change lives of someone who was being prepared, a child that was being prepared for, a family that was being prepared for death, walks out of the hospital 17 days later, otherwise healthy. So that was a great thing right there. So this is a pretty cool thing. I'm going to be wrapping up soon. Life 2000. How many of you have seen this? Anyone seen this? Life 2000. So those at my facility have seen this device. It is a new open proportional ventilation system, and it is a very unique ventilator that is out there that is going to help transition from the hospital setting to the home care setting. So challenges of traditional NIV therapy, and I think you've heard a lot of this here, so I don't have to spend a lot of time. There are a lot of limitations, whether it be interface, whether it be the size, whether it be asynchrony, mobility limitations. So I don't know, how many of you have used these devices? LTV, you have the Trilogy. I don't even know what that is. ResMed, but look at the weights: 15 pounds, 11 pounds, 7 pounds, right? They're a little bit heavy. And we're talking about patients who are already compromised with their respiratory status, and they're having issues with mobility. And those are the type of devices they have to drag around with them when they're trying to, do certain things. And can you imagine a patient confined to a ventilator at home, or a BiPAP at home, or some type of device at home, and them being at their child's wedding and dancing with them there? Can you imagine that? Just picture that for a moment. What could we be doing for that patient to improve not not just their status as a patient, but their quality of life. And you'll see a lot about this machine here that can actually do that. So current home NIV for COPD options, and even though it says COPD options, there's a lot of different times that are happening here, and you could see the way how these devices are confining, and and the way how they have to go about using them. Those are a couple what are there. Introduces the Life 2000 ventilation system from the Breathe Technologies. Thanks to the Breathe company for letting me use these slides, and I was able to put it together. It is intended to provide continuous or intermittent ventilatory support for the care of individuals who require mechanical ventilation. The system is suitable for the use in home and institutional settings and is not intended for ambulance or air transport. So it's really built for the hospital and then to transition to home. It is a proportional open ventilation, POV. Life 2000 is the only ventilator with this mode of ventilation that supports patient comfort during ambulation. What that means is that as the patients are mobilizing and their demand goes up, the open proportional ventilation system provides more support to that patient. And as their demand decreases, the ventilator senses it and lowers the amount of support. Isn't that such a smart technology to be having in here to get our patients comfortable on what they're actually receiving from us, right? That's actually, so remember you were seeing the ventilator in a big dock? That's actually the dock. This is the ventilator in a transport version, and this is the great things. It's a wearable ventilator. It is a ventilator that undocks from the compressor and can be used in extended range mode and with alternate pressure source for free mobility. So connecting with a 50 psi source on a tank. You have a 4-hour battery life, right? It weighs 1 pound. It weighs 1 pound, and it's a discrete size. It can be attached to your belt or to your waistband. We've actually seen it done where it comes with a clip for that ventilator, and it's a great thing to know and to have for our patients. So this is another great point here. So the interfaces are their nasal prongs, and then also recently the FDA finally approved the Uconnect. So the Uconnect actually connects to the mask, it connects to the ET tube, it connects to the trachs. So you can actually get patients on the Life 2000 and mobilize them more effectively in the hospital, and also when they go home they can be on these devices as well. So it's such a great thing to have. So it's adaptive to patients' continuous ventilation needs up to 24 hours a day. So there's a standalone version, there's the extended range, and then there's the stationary option. And the system offers 3 distinct clinician set parameters. And if you could see those 3 little parameters there, there's ambulation, there's sitting, and then there's laying down. Okay? And ambulation and mobility, and I don't know how many of you have heard about early mobilization projects within institutions. That is a big push right now. And for institutions that are embarking on these projects, these are the type of machines that you want to have to be able to empower your staff and to have them to be available to use them. So, and it's not just about walking a patient, it's about progressive mobility. It's about progressive mobility. So there's dangling, there is the sitting in the bed position. Then you take the step of mobilizing patients on this device. And this device is not only recommended for patients who are on BiPAP or who are on ventilators. How many of you have seen a patient that you just went to give a treatment to, they're on nasal oxygen, but you know they cannot reach the bathroom very well? Any of you? You know they have trouble breathing, just getting to the restroom or even walking down the hall. This is the device that we've seen benefits with. We have actually had a patient that we trialed this on at our facility where she would normally walk, I think it was 4 miles a day. Just, she would walk 4 miles a day. She was an ex-pediatric nurse or a NICU nurse at a facility for many years. And you should have heard the story, she said, where she said, I've lived all my life and helped my patients, and now I'm sitting in bed and I need someone to help me. What is there to help me walk again? That's where my joy is. Introduces the Life 2000 ventilator, where now we had to put her on a BiPAP and roll her around with this big device. She was able to clip a ventilator to her belt, to her waist, and be able to walk around. She walked around the whole unit that day and she was perfectly fine, and she saw the benefit of it. To credit to her, even before we even got the ventilator, the Life 2000, she actually ordered one for home, and she went home with it. Even without Medicaid or whatever insurance she had, she bought it cash because she said, this changed my quality of life, and it can impact your patients as well, okay? So So Life 2000, you're trying to ventilate your patients and mobilize them. They can even exercise. You can see it on this young man's belt here that he actually has that ventilator clipped to him, and he's on the treadmill. Think about putting a patient on a treadmill with a transport vent that you have right now. Or think about a patient being able to walk and just, they're fine. You're just observing them and helping them in whichever way possible. So it's the Life 2000 ventilator in the hospital setting, mechanical ventilation, early weaning, alternative NIV, enabling early mobility, improving pulmonary rehab outcomes. Think about your patients that are being readmitted for breathing issues at home. If they were to have this device at home, we would see less readmissions because they will not need to come to the hospital to get a BiPAP. They would have had the support at home that they needed. And those are the type of results we want to see. So early mobility initiatives for mechanical ventilated patients, those are the type of setups you see, 10 people around one person, and a lot of the RTs in here have started mobilizing intubated patients, trach patients, and that's the type of setup that you have. It's the size of the equipment and the staff availability that we have, and why you need so many staff sometimes. You have so many different tubings and things wrapping all around the place. One person pushing the vent, one person pushing a stretcher, there's so many different things. But if you could eliminate a huge ventilator component and have it like on something much smaller, it can benefit those patients. And mobilization and rehabilitation can play an important role in decreasing the duration of mechanical ventilation and hospital stay and improving patients' return to functional independence. In a nutshell, what that means, mobilizing patients while they're in the hospital improves outcomes. It helps us decrease vent days. It helps us so much in a lot of different ways. So targeting the triple aim of healthcare, so you have patient satisfaction, you have quality of care, and you have cost efficiency. And I'm not going to go through all of these, but in a broad spectrum, you can see that you're getting satisfied patients because they're being mobilized and they're getting off the ventilators and off of the ICUs quicker. You have quality of care because we're helping them in so many different ways that we weren't already. And then you have cost efficiency because you have versatile treatment options, you have simple patient setups, and servicing efficiencies, and the PMs on these devices are 1 to every 2.5 years, which is a great thing. So an overview again, Life ventilation system in the home setting reduces work of breathing, improves ventilation, increases oxygenation, and supports ADL gains. Who can benefit? COPD patients, neuromuscular disease patients are characterized by some of the combinations of the following: multiple exacerbations, chronic hypercapnia, patient placed on NIV on admission, shortness of breath. So shortness of breath covers a lot of different disease processes that we can help our patients with as well. So the value proposition is this. This is a slide you need to take home with you. Is that ventilation plus oxygenation plus ambulation equals to better outcomes. And there are studies to back it up, and when you get these slides, you can take this picture back to this slide back to your facilities and advocate for this. There are grants that hospitals can actually get to get these devices in-house, and you need to be able to know about those things and take it back to your departments, and this is a wonderful thing. And not just the Life 2000, the MetaNeb, the sinusoidal bronchotron, all of those were from grants, from donations to institutions that we were able to get these devices, and those are the things you can utilize. So it's not just about the Life 2000s, but all of these innovative devices that you can potentially have. And that's the value proposition that you want to have here as well. So I'm going to move along. So the Life 2000 summary: current NIV devices can present patients with adherence and mobility challenges. Open ventilation technology enables and encourages patients to increase their activity while addressing their ventilatory needs. And the Life 2000 provides continuity across the care continuum. It stretches across the hospital straight to the patient's home, and that is the thing that we want to impact right now. The overall summary for today: we need to advocate for higher levels of airway clearance and mobilization therapies and devices within our institution. Get ourselves more involved with using various types of equipment, and most importantly, get innovative, as I mentioned before. Questions? Amen. Any questions? No?
Can I take a picture of you?
Okay. You have questions, sir?
Yeah, regarding the way how you do you switching the patient on the volume to pressure control when you're putting in live PD, what's the basis, and can we do it also on the adult pediatrics?
Well, sure. So most of our pediatric patients, if I heard your question correctly, most of our pediatric neonate patients are on pressure already. A lot of them are, some of them are, and they're on PRVC or volume control, right? So potentially, we don't like doing it on volume because we're adding pressure, and when you add pressure to volume, it's a high likelihood you can cause more issues to the lungs, barotrauma issues with that. So, but what you really want to do is pressure is the way to go when you're actually doing the therapy, and the transition in all the different aspects of care, we've seen benefits with pressure, and we're able, the big point is we're able to manipulate the eye time more clearly, right? So we're able to manipulate that eye time and configure it to where we want it to be to get more effective therapy. I don't know if that answered the question.
Yes.
Oh, okay.
Follow-up question probably about bronchotron.
Sure.
Do you use bronchotron with incorporate with the ventilator, the regular ventilator?
So great question. The metanab needs a mechanical ventilator to provide airway clearance to the intubated and trach patient. The sinusoidal bronchotron takes over the complete work of breathing. It provides ventilation, oxygenation, and airway clearance all in one with nebulization therapy, and you can also do nitric oxide therapy as well. So it is a complete takeover from the ventilator. So while the metanab needs to be working in conjunction with a conventional, sinusoidal bronchotron takes over. You don't need a ventilator. You put that on standby and you ventilate completely with the sinusoidal bronchotron. And the sinusoidal bronchotron is a transport version for intermittent use up to 4 hours. The VDR is the bedside version of that ventilator that can run continuously. And some institutions like burn units and different things like that, ARDS centers, lung centers, they go straight to VDR because you're ventilating, you're oxygenating, and you're clearing out the lungs all at the same time.
Thank you.
No problem. All right, thank you.